Good morning.
Yeah, good morning. So we want to like kind of continue where we stopped from yesterday. So, can anybody give us an idea of where we stopped yesterday? What we discussed yesterday, the summary of what we discussed yesterday. Can anyone just recap? Talked about the neurocutaneous disorders. Talked about herniation. Yeah,
We talked about Huntington.
Huntington's disease. Yes, as well. So today we want to just quickly go towards the spinal cord lesions as well as the brain tumors. Yeah, so there are a lot of things that we're going to learn today that are really, really high yield for the exams. The spinal cord lesions are high yield, the brain tumors are high yield. So I would indulge you guys to like pay utmost attention to what we're going to talk about today. So let us begin basically. So um So this is the topic we're going to talk about today. Just as a way of trying to give our discourse today a headline. So this is what we're going to talk about today. We're going to talk about the tumors, basically the adult tumors. And yesterday I was talking about the mnemonics that I gave you guys, right? I said when you have adult tumors, so adult tumors, right? I called them the GM shop, the general's manager's shop, right? That's what I called it. And I said that this G stands for glioblastoma, the M stands for meningioma, the S stands for schwannoma, right? The H stands for hemangioblastoma, the O stands for oligodendroma, and the P
Hi,
stands for pituitary adenoma. You
is a
said?
little blurry. Can't see. Are you able to use like a
Okay.
darker ink? A little blurry. We can't see what you're
Yeah, let me
writing.
use okay, so let me write that. Let me use a darker ink. Sorry guys. Let me use a darker ink, right? Sorry. So I mentioned the GM shop, right? The general manager's shop as like the mnemonics that I gave you guys for the adult tumors, right? And I said the G stands for glioblastoma. Can you see it now?
Yes, thank you.
All right. Yeah, the G stands for glioblastoma, right? The M stands for meningioma, right? And then the S stands for schwannoma, right? The H stands for hemangioblastoma, so hemangio. So like a blood tumor that affects majorly blood vessels. The O stands for an oligodendroma. And then the P stands for pituitary adenoma. So the mnemonics I gave you guys the last time we met is called General Manager Shop, right? So this is basically just like more like a summary of the tumors that we're going to talk about today, right? So I'm going to talk about all of them individually. I'm going to tell you guys some little tips on how to recognize them in the exams. And then I'm going to show you guys a diagram, a CT scan, and preferably a histology, just to kind of like make it stick and reinforce it. Although we're going to have a slideshow at the end of the neurology session where I can further buttress all the things we have done so far, okay? So we're going to start firstly with the glioblastoma, right? Glioblastoma, right? So the glioblastoma it basically is a very high grade tumor, right? High grade. It's a high grade tumor. So there's something known as staging and grade of tumor. Grades, all right? The grade and the stage of the tumor, right? So the stage typically just shows like how far the tumor, spreads to or metastasizes, while the grade just tells the level of aggressiveness of the tumor, right? So when you say a tumor has a very high grade, you're trying to say like, oh, the tumor is very aggressive, meaning that it has a very kind of like poor prognosis. So the higher the grade, the poorer the prognosis, right? Yeah. And then the stage just determines the spread, basically, right? The spread of the tumor. So as it left its area of primary confinement and it goes to nearby tissues, that's a higher stage, right? So the glioblastomas basically are tumors that have a very high grade. They're rapidly invasive, and the cells that are basically affected in glioblastoma is actually the we call them the astrocytes, right? So the astrocytes are majorly involved in this tumor, right? And so, as you would guess, the marker of this tumor is actually the GFAP. Now, there's something quite unique about the glioblastomas, basically, and that's that they are the only tumors, basically, that crosses the midline. So let me draw a brain here, right? So this is like a brain, right? And so this is the false cerebri. This is the tentorial cerebelli. Yeah. This is the cerebellum that's located here. This is the tentorium cerebelli. This is the tentorial cerebelli. This is the false cerebri, right? And so a tumor, a glioblastoma that grows at this part of the brain can spread to this other part of the brain. Like can grow and extend to that part, right? So it crosses like kind of like the midline, yeah. And if you look at this closely, it's kind of like a butterfly shape. Yeah, so on the CT scan, I'm going to show you guys this soon though, so that you can just um let me show you guys here. Right. So this is what I'm trying to talk about. Like you can see that this like kind of like the false cerebri, and then you can see that the tumor grows, horizontally. It crosses the midline, and it's the only tumor basically that crosses the midline. So that's really high yield for you guys to know. That image as well is also very high yield for you guys to know as well. What's the high yield thing you need to know about it again is the histology. How is it described basically? So it's described as coming. So it's described as what we call pseudopalisading. So I'm going to explain what this pseudopalisading means, right? Pseudopalisading cells, right? So basically, what happens here is that I don't know if you guys have been to a stadium or like what do you call it? Like you guys watch soccer or football, and then when you go to the pitch, you notice
Please,
that
can
like
you repeat it again? Oh, sorry, can you repeat it
can you hear
again?
me? Okay, so we have what we call
Can you repeat?
pseudopallisading cells. Or what do you
Mm-hmm.
want me to repeat?
This point,
Can you hear me, Doc? Can you
I
hear me
didn't
now?
get it.
Yes, we can hear you. Yes,
Okay,
yes.
so I was talking about the histological description of like a glioblastoma. So this is like histology, right? So I'm trying to explain what it means. So there's pseudopallisading pleomorphic tumor cells, right? That's what you see on histology. So I'm trying to explain what the word pseudopallisading means, and when you see it on histology, what it represents basically. So I don't know if any of you have been to a soccer pitch, and so I'm trying to draw that for you guys. Like this is a soccer pitch, right? And then you have like spectators watching over here, right? This is the first part of the stadium, right? And then you have a row here, two rows, and then the next person is on top, right? In the stadium, the next person is on top, the other person is on top, just like that you have in the stadium, right? The same thing happens, right? All across, right? Anybody that watches soccer will know this so well, right? Or watches football, or you watch live football. So that's basically what happens, right? So like what happens here is that the tumor cells, these are like the tumor cells, right? They're like you see them arranged in a kind of like line fashion, right? You see them arranging themselves in a line fashion, right? The same thing here. So you see one here, 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 you see one, just like that. So they arrange themselves round, like around the center, right? So that's what like happens like with the cells. So anytime you think about the glioblastoma, the first thing I want you to remember is this football pitch, right? Football pitch. And they're like spectators watching the match, right? And then these spectators are the tumor cells, right? And they're arranged in this line arranged manner, right? So they're like arranging, they're following themselves, and it's like the tumors here are above these cells, the ones here are above here, and likewise the same thing round, right? So this is what you see on histology when you see a glioblastoma. And then what happens is that in the middle of this pitch here that you're seeing, this place that I draw that looks like a football pitch here, right? You see a cell that has necrosis and hemorrhage. So there's necrosis and hemorrhage. Necrosis and hemorrhage, right? That's what you see. So on histology, I'm going to show you this, you guys, what this looks like. So you can see like this on histology. This is what I was trying to drive, call across to you guys. So I was telling that when you see a histological slide, most often than not, when you see this light pink, not dark pink like this, not dark, but like light pink like this, most often than not, it's kind of like denotes inflammation. Not in all the cases, but like in like some cases, kind of like a way of remembering it basically, right? So there's an area of necrosis and hemorrhage, right, in the center here. And then you can see the cells, like these tiny cells around this area here. And then you can see that like this part that is closer to the center of necrosis is down. And then you have an upward, kind of like something like this, right? Kind of like it's going down this way, right? Like this side is like folded. Like I don't know how to describe it so that you guys can understand what I'm trying to say. Kind of like it's folded, like you fold your sleeves, right? When you fold your sleeves, you notice that when you fold your sleeves, it gets a bit higher and higher and higher. So basically, that's what's happening on the histology here, and you can see the same thing with this region here. So you can see the cells. There are cells that are closer to the central area, and then there are cells in the middle here, and then there are cells at the outer part here. I don't know if you guys see this, right? When you see this histological slide of this central area of necrosis and hemorrhage, and then you see cells surrounding it like this, that one cell is lower, the other cells are becoming higher, and this side becomes higher. When you see that, that should take your mind to a glioblastoma, okay? And then one of the early signs of presentation these patients have is that they tend to have a lot of seizures and kind of like muscle weakness, lower muscle weakness most of the times. It's usually found around the cortex. There's not really clear-cut particular preference for any cortex, right? That the glioblastoma kind of like develops in. But what you need to know for the exams basically are these things I'm telling you, right? That it can cross the corpus callosum, as well as the falx cerebri. You can cross it. You can cross it. You need to know the marker. You need to know how to recognize it on the CT scan, which is what I showed you guys here. This is how you recognize it on the CT scan. You can see that this area is kind of like hyper pigmented, showing you that it's kind of like undergoing fibrosis, kind of shading off, shading off the necrosis from spreading out. Okay, and this is like the area of necrosis going on, and you can see that it has crossed the midline. So it was initially here, maybe it was a small tumor here, and then it grows horizontally. So it grows kind of horizontally to the other side. I don't know if that makes sense to you guys. Do we have any questions about the glioblastoma before I go on? Okay, so the next one I want to talk about basically is an oligodendroma, right? I want to talk about an oligodendroma. So the O here, right? I want to talk about the O here. Okay. So kind of like so I'm going to talk about the oligodendroma. The oligodendroma is not really kind of like aggressive tumor like that. It's not so aggressive. And one of the ways you recognize it in the exam, basically, it's its location. So the oligodendroma has a very strong predilection for the frontal lobe. I don't know why, though. I don't know why. So it loves the frontal lobe so much. That's the first thing you're going to do. So anytime you see a tumor, you want to like, you're kind of like scared of like picking an oligodendroma. If it's located in the frontal lobe, you have like a 95% chance that that's an oligodendroma, right? 95% chance that that's an oligodendroma. Another thing about it is that for a very weird region, it's usually calcified. It's calcified. It's a very calcified tumor. It's a calcified tumor, right? And then let me show you guys a picture of it, right? So this is how oligodendroma looks like. Basically, you can see that this is like the frontal lobe, like, so this region is like the frontal lobe, and it kind of like grows here. I'm going to differentiate this on meningioma later on so that you guys can have an idea of kind of like what's the difference on a CT scan, so you can understand it better. But the most important thing I want you guys to know here is the location. You can see that most of the tumors kind of like are located elsewhere, but the oligodendroma has a kind of like strong predilection for the frontal lobe. That's the first thing you need to know. The second thing you need to know is that it's often calcified, so it kind of like has a lot of calcification going on. And then when you look at a histology, I think when I was talking about the cells of the CNS, I mentioned that the oligodendrocytes kind of look like, how many of you guys fry eggs, right? So basically you have the is it the yolk or the egg white? Yeah, you have the egg white, and then you have the surrounding like kind of like yellow part. Or I think it's the opposite. This is like the yellow part, and then this is the surrounding white part. Right, kind of look like you're frying eggs. And so anytime you guys think of an oligodendroma, you kind of think of like a chicken wiry pattern. Anything has to do with the chicken. So a chicken produces eggs basically. So that's how I want you guys to like kind of associate it in your mind. So It has this egg whites kind of like presentation, which is what we just saw in the histology here. You can see that it's kind of like there's a center part that's kind of colored, and then there's like a white part that's surrounding it. So when you see this on the histology, where there's a central part and then like there's a white area surrounding it, right? I want you to go, I want your minds to go to oligodendroma, right? Oligodendroma. This is how it typically looks on histology. This is very easy to remember because like when you think of an egg, you just think of it. It's kind of confusing basically because you might think that it's like fat cells, but what happens in fat cells is that you don't see this basophilic nuclei, right? This basophilic central structure here. Rather, for fat cells, you just see like an empty whiteness, right? Where like the whole place is white, basically on histology, right? Kind of like something like this. There'll just be whiteness in the for fat cells. So it's kind of like different, so you don't confuse it, right? It doesn't really have a genetic doesn't really have a gender predilection. I think it occurs in both females and males almost equally. That's really the high yield thing you need to know about oligodendroma. It's not as commonly tested in the exam as like a glioblastoma or the other tumors or a meningioma. Yeah. So I'm gonna move next to the next tumor that we just need to know. Right? Tumors are kind of boring, but like I'm trying my best to kind of make it like simple and what you need to know for the exam. You don't need to know everything for the exam. What you just need to know for the exams are these things that I'm highlighting, and then when when you're revising, you can go through the notes, you can go through first aid as well, and just try and reinforce those things that you feel you couldn't remember in the class, right? And the next thing we're going to talk about is the meningioma. Meningiomas are a very special class of tumors. Yeah, the last thing I forgot to mention about most of these tumors is that about 95% of them are managed surgically, right? Surgically. All the tumors, basically, all the CNS tumors are really managed surgically. And the alternative to that is radiotherapy. Can anybody tell me why chemo is not so efficacious or effective for brain tumors? Can anyone have an idea? Can anybody just wild a guess why chemotherapy is not so effective in managing these tumors? Anybody can hazard a guess? Yeah. So the blood-brain barrier is also a very significant. It's a very significant
And
barrier to therapies. Yeah,
the
chemotherapies
structure
are
of the cells,
not a lot of them. Yeah,
the cells, the layout of the cells there.
yeah. That's another reason. The BBL is one of the like structures that prevents most of the chemotherapeutic agents from getting to the brain. So chemos are not as effective as radiotherapy and surgery. Surgery is like the most effective, and then you now have radiotherapy, right? So let's go on, right? So the meningioma is quite unique in its own way because it has a genetic predilection, it has a gender predilection, so it affects more females than males, right? It has affects more females than males. Some say the ratio of 3 to 1, right? Some authorities say the ratios of 3 to 1. So for every one male that's affected, 3 females are affected. And the molecular basis for this basically is that estrogen receptors, right, are implicated in the pathogenesis of the disease condition. That's why it kind of like affects females more. So estrogen receptors play a significant role in the pathogenesis. I don't really know how it works, but that's what I've read and that's what I've known. Even before I wrote my step, I knew this. And so it tends to have a strong predilection for females, right? And the part of the brain that's affected, or the cells that are affected, are the arachnoid cells. Arachnoid matter, so cells. So the arachnoid matter is where you commonly find this, right? Cells. Now, these cells are also calcified, just like the oligodendrocytes. But there's a difference, and let me illustrate that here with this. So, this is a meningioma. You can see it's calcified. This is a meningioma. You can see it's calcified. But the differentiating factor between these both and those that when you look at this, the oligodendroma, you can see that the calcification is just limited to that region. There's no extension laterally, like towards the edges of the tumor, right? There's no extension here. But that's in contrast to a meningioma. You can see that there's extension here and there's an extension here. And that extension is known as a dural tail. Dural tail. Let me just write that out for you guys. So that's called the dural tail. The dural tail. So when you're stuck in the exam and you're trying to like differentiate between the two tumors, or you see an imaging, just check what the tumor has, right? The tumor has a dural tail, most likely a meningioma, because a meningioma can be found in the frontal lobe as well. So if you see this, if you see the tumor and then you see it's calcified, and then you see this extension here known as the dural tail, which is an extension of the tumor into the dura, you can safely call that a meningioma, right? You can safely call that a meningioma. Okay. So the next thing we need to know about it is the histology. What do you see on histology? What you see on the histology is simple, very, very simple. It's something that you can always remember. And I'm sure that while you have been reading for your step exams, I'm sure you have encountered it. It's called a Samoma body, right? There are like, I think, 8 other conditions that you can see this. And that is very high yield. You guys need to know this for the exams. This is very high yield. This is very high yield for the exams, right? And you need to know how to recognize it. So what you see for a meningioma is that you see what we call a laminated calcification. A laminated calcification, right? So let me show you guys what it looks like. So on the histology, are you seeing this whorl like, it's like whorls. Let me use the word again. So whorl like, it has a whorly structure. So whorly, like something like this. Let me show you guys. Yeah, so this is how you see it on histology. So when you see things like this laminated circular kind of like calcification on a histology specimen, you should think of a Samama body. So this is one of it. This is another one. And you can see these tumor cells are around here too. Almost the same thing here. But this is like the perfect example I can use, right? You can see that it's whirly, like, I don't know how to put it, like whirly, like it's circular arrangement, right? All I know, I can see that the cells are surrounding it as well. Like cells, tumor cells are also surrounding it, right? When you see this in an exam, in the step 1 exam, I want you to think of meningioma. Yeah, I want you to think of meningioma. That's where I want your mind to go to. Okay. Is that clear? Do you have any questions about meningioma? Are there any questions about meningioma? Yeah, okay. So let's continue, right? Now, the next one we're going to talk about, quite simple, is the hemangioblastoma, right? This one is pretty much straightforward. We talked about it in von Hippel-Lindau syndrome, right? And hemangioblastoma, right? So the hemangioblastoma, right? It's one tumor that has a very strong preletion for the posterior fossa. So the posterior fossa is where it's commonly located. Posterior fossa is where it's commonly located, posterior fossa. So the organ or the structure that you find it most is the cerebellum. I don't know why though, it likes this region. So these are basically just blood vessel tumors in the brain, blood vessel tumors in the brain. And one unique thing about this tumor is that it secretes erythropoietin. So you might see a patient that has a tumor, and then in the question, they might tell you that the patient is having, what do you call it? The patient has polycythemia. The patient has a tumor but has polycythemia. So when you see that in an exam, I want you to go straightly to a hemangioblastoma. Yeah, apart from that, it can be located. It's one of the most ubiquitous tumors in the CNS. Not only is it found in the cerebellum, it can be found in different regions, basically. You can find it in the retina. You can find it in the retina. You can find it in the retina. Like, you can find it in the retina, right? You can find it in the pons. You can find it like it's one tumor that you can find anywhere. You can find it in the spine. Yeah, you can find it in the spine. Like, I'm not joking. I'm not kidding you guys. You can actually find it in the spine. Yeah. There are 2 tumors that can undergo, rather 3 that can undergo, was it 2? Yeah, 2. A meningioma is one of those tumors that undergoes what we call a drop metastasis, kind of like in the brain. You can just go to the spinal cord. You can just drop some tumor cells down the spinal cord. A medulloblastoma also does that. So those are the 2 like tumors that I know that does that. So what's the high yield thing you need to know about hemangioblastoma? I think the high yield thing you need to know here is the association. So what is it associated with? I don't need to say too much about this. What's the commonest association of a hemangioblastoma? Can anyone help out? Commonest association?
Yes, the VHL.
Hemangioblastoma?
VHL.
Yeah, so the
VHL.
VHL syndrome is the commonest. Yeah, so it's the most commonest association of the hemangioblastoma. Let me show you guys how it looks like. So this is how an hemangioblastoma kind of like looks like. It's hyperdense, and you can see that it's located like kind of like in the cerebellar region, the posterior fossa. Now, this kind of like varies from a schwannoma. So like, I'm going to get to schwannoma. I'm going to show you guys the location. So in the CT scan, you can use the CT scan, the location of the tumor in the CT scan to kind of like make your diagnosis, right, for certain tumors. And then you can see that there are like blood vessels, right? Numerous blood vessels. These thick pink colors that are like kind of dots, numerous blood vessels. And this is how you recognize it on histology slide. Numerous blood vessels, abnormal blood vessels that are forming, that have contain, blood cells, and that's why it's like that, right? Okay. The walls are very thin and friable, and hence they are very prone to rupture, right? Very prone to rupture. These walls are not so well formed, and hence these vessels you're seeing that are easily formed can easily rupture. Yeah, it can easily rupture. So you need to know this for the exam. Located in the cerebellum, you can also see it in the spine. You can also see it in the pons. You can also see it in the thalamus. It's one of the most ubiquitous tumors, brain tumors that you're going to find. And one of the strongest association is von Hippel-Lindau syndrome. You must know this for the exam. Okay. So let me continue. Do you have any questions as regards hemangioblastoma? Okay, so let me go on. All right, let me go on. So after hemangioblastoma, I think the last one we're going to talk about, last 2, is we're going to talk about the schwannoma, and then we're going to talk about pituitary adenoma, but I don't know why I've spent so much time there because it's pretty much easy to figure out. So we have a schwannoma. So these are like tumors of the Schwann cells. So they might tell you guys in the question, they might frame the question in such a way that like they identify the tumor for you guys. Like they might show you a slide, and then let me show you guys schwannoma. They might show you a tumor, right? Let me just bring this down, right? They might show you a tumor like this is where the schwannoma is. It's usually located in what we call the cerebellar pontine angle, right? So this is like the cerebellum. This is like the pons. From here to here is the pons, and then from here to here is the cerebellum, right? And then it's located in angle between the pons and the cerebellum. So it's located in the cerebellopontine angle. We call it an angle. It's like an acute angle between the pons and then the cerebellum. So it's usually located in this angle here. And it tends to affect the cranial nerve 8. It's kind of like affects the cranial nerve 8 a lot. Kind of affects that nerve a lot. So you have to know that for the exams. And what you need to know about the schwannoma, I was trying to get to something before I yeah, they might ask you this in the question. They show you this CT scan, and then they ask you, okay, the tumor that you can see in this image is derived from which cells? And then they might tell you, okay, the first cell, they'll tell you the neuroepithelium. The next cell they tell you is like the mesoderm. The next cell they tell you is the endoderm, and then they will not put the neural crest cells. So what do you think the answers would be, guys?
Neural
That's how they
crest
usually bring
cells.
it. Yeah, neural crest cells. So that's how they usually bring it in the exams. So you have to like take note of that, and then you have to know the angle, the where it's located. The next thing you need to know about the schwannoma basically is that it has a tumor marker. Does anybody have an idea of what the tumor marker is?
S100.
Yeah, so X100. Yes, thank you, Dr. Sevara. So X100 is very highly suggestive of a schwannoma, so S100, right? Affects cranial nerve C, N, B, 1, 2, 3. So cranial nerve 8. That's another thing you need to know about it, okay? And then I've shown you how you can recognize it on histology. The next thing I'm going to show you guys is how do you I showed you guys how to recognize on the MRI and the CT scan. And then the next thing I want to show you guys, how do you recognize it in histological specimen, right? So basically what you're looking for is that there is two parts of the histology that will tell you it's a schwannoma. So the first layer can be hypercellular. That's the first thing you need to know. And the second side can be hypocellular. And this hypocellular tends to have what we call a myxoid material. Myxoid. So kind of like strong, like, or loose connective tissue, myxoid materials there, right? Yeah, so when you see it on histology, it's kind of like a biphasic area. So it's like a sandwich, basically, right? So like the bread is like the hypercellular area, and then the beef and the cheese and the other things are like the hypocellular area, right? So let me show you guys how it looks like. That's how I remember it. I just think of the sandwich or a burger, and then I'm able to recognize it. So this is like the bread of the burger, kind of like hypercellular. You can see a lot of cells there, kind of like, interspaced within themselves. And then you can see that this is like the meat part of the burger. And then you can see kind of fenestration. When you have the meat you used to do burger, you notice that there are like tiny holes in the meat, like tiny holes in the burger meat, right? So that's how I kind of like remember the schwannoma, because like it looks like a burger. So like the bread is like the hypercellular area, and then the meat that has a lot of holes, it's like the meat and the cheese that has a lot of holes is like the hypocellular area. Kind of like it helps me to remember, how a schwannoma looks like. Okay. The last one I'm going to talk about is the pituitary adenoma. This one is pretty much straightforward.
Which one is the schwannoma out of the pictures? Which one?
Okay. So this is how a schwannoma looks like. This is how it looks like, right? You can see that this area is hypercellular.
Which one?
Like it has a lot of cells. This blue. Huh?
Okay. All right. The last one.
Okay. Have you seen it, or do you want me to explain it for you?
Oh no, I can see it, but it's the last one, right? The last picture.
Yeah, it's the last picture. Yeah, it's the last picture.
Okay. All right. Thank you.
So The last thing I'm just going to talk about is the pituitary adenoma. Very, very, very high yield. It comes out in endocrinology. We're going to deal a lot about it in endocrinology. But what I need you guys to know basically is that patients that have pituitary adenoma, you can have two types. You can have the functional and the non-functional, right? So like the functional ones are the ones that secrete the hormones, prolactin, like more like a prolactinoma and the likes. The non-functional ones are the ones that have mass effects, so that they kind of like compress nearby structures. And one of the structures that the pituitary adenoma compresses is the optic chiasma. So the optic chiasma is something like this. Let me kind of like draw it so that you can have an idea of how it looks like. Yeah, so this is like kind of like the retina. Let me kind of like draw this so that you can understand. Yeah, this is like the two retinas. Yeah? And then one part comes this way, right? And one part comes this way, right? Right? And this part crosses over, like, and this part like kind of like goes this way, and you have this part that kind of like comes like this way, and it kind of like goes here, right? And then you have this part that kind of like goes here, and then you have this that kind of like goes this way. So this part here you're seeing, this middle part is the optic chiasma, right? And so the pituitary adenoma kind of like compresses here. For the non-functional ones, compresses here. And what the patient has is that it blocks fibers. So this one takes more like fibers from this part of the eye, and this side takes fibers from this part of the eye, right? This side here takes fibers from this part of the eye, vision from this part of the eye, and this here takes vision from this part of the eye. So it kind of like compresses the middle. Although when we get to ophthalmology, I'll explain that as well. But basically, what the patient will have is homogeneous hemianopia. So basically, the patient can see. So the patient can only see kind of like the nasal part of his vision. So this is like the temporal, this is the nasal part, this is nasal, this is temporal. So this part is kind of like blocked. The temporal side is blocked, and then the patient can only see at the what do you call it? The nasal part of the eyes. I don't know if that's clear, guys. Shouldn't dwell much on it. So I think that's basically the end of the adult tumors. Do we have any questions about the adult tumors?
I have a question.
Yeah, sure. Go ahead.
Yeah, you talked something about the tumor marker. Does all the tumor has tumor marker, or is only the schwannoma?
The schwannoma and the glioblastoma have tumor markers that I'm aware of and that's commonly tested. The oligodendrocytes, I don't think it has anyone that's tested in the exam. Meningiomas doesn't have anyone, but I think the closest association is the receptors that are affected. And the receptors are actually the estrogen receptors. That's why it's more common in females. But I don't think there are any other ones. The other ones, I don't think they have kind of like the tumor marker that you should bother yourself about for the exam. The tumor marker you need to know is for glioblastoma and then the schwannoma. Those ones are commonly tested in the exams, right?
Yeah. Mm-hmm.
Yeah, so
thank you. What are tumor markers?
Tumor markers are like kind of like chemicals that kind of like are secreted when a particular cell of that particular origin goes into haywire and starts differentiating and starts producing these proteins. So they kind of like spill into the blood vessels, and they help us kind of like pinpoint the exact tumor or pinpoint the exact cell that tumor is coming from. So they're like kind of like proteins. Should I put them proteins? Yeah, that help to kind of like give an idea of where the cell that is causing that particular tumor, where is it arising from? Basically these things are normal cells. These things are normal proteins in those cells, right? So the S100 is something that the schwannoma produces. But when it goes uncontrolled, when the schwannoma starts having this cancerous potential, it starts overproducing these tumors, right? Starts producing these over tumors. So when you take a blood sample of the patient and then you're seeing a very large amount of X100, it goes to tell you that, oh, something fishy is going on, right? You are supposed to
Yeah.
see it, but you're not supposed to see it in a level, in a like greater than a particular level, right? You're not supposed to see it greater than a particular level, basically.
Okay, thank you.
Are we clear, Dr. Margaret?
Thank you, doctor. Thank you so much.
Yeah. So the next thing we're going to talk about.
Thank you. Mhm.
Is the childhood tumors. Yeah. So the childhood tumors. Yeah, you're welcome. So the next one we're going to talk about is the childhood tumors. The mnemonics I made for it, very simple. So way you can always remember it, right? So the mnemonics is called PACE-MED, right? So the MED stands for medulloblastoma, right? Diamoma, right? The C stands for craniopharyngioma, right? The A stands for astrocytoma, and it's differentiated from the ones you have in the adult tumor. This one is more pilocystic. And then here we have the pineal gland tumor. So we're going to talk about each and every one of them. I'm going to kind of like explain each and every one of them and the ones you need to know for the exams, the ones that are actually very high yield. So the high yield ones, the craniopharyngioma, the astrocytoma, the medulloblastoma, yeah. And the medulloblastoma, basically, the reason why it's high yield is because of the cells that are involved. You need to know them for the exams. The ependymoma, basically is more kind of like more straightforward. So basically, what happens? Let me start with the ependymyoma, right? Let me start with that one basically. So this one is usually located around the fourth ventricle, usually located in the fourth ventricle. And if you remember, we said that the ependymal cells are cells that are responsible for lining the ventricles, right? And they help in CSF production, right? So it's usually located there. It doesn't have any tumor marker. I'm trying to see if I can get an image for you guys to see. Okay, they don't even have an image. Here I can show you guys. Okay, we have. Yeah. So this isn't it. No, this is not it. No, okay. So I think this is it. Yeah, this is it. So basically, this is like kind of like the tumor. Like you can see, this here is like kind of like the tumor, right? And then it's expanding, it's growing, like kind of like starts here and then grows downward. So basically, it starts in the fourth ventricle, and I told you like kind of like the fourth ventricle forms the roof. The fourth ventricle the vermis of the cerebellum forms the roof of the fourth ventricle. So that's how you're able to recognize it, right? It's mostly located in the fourth ventricle. So when you see an MRI, basically highlighting this hyperdense area around where the cerebellum and kind of like the fourth ventricle is supposed to be, you should be thinking more of what do you call it, on ependymoma, right? Ependymoma. So that's what should come to your mind. It's not really high use for the exam. I wouldn't tell you to bother yourself about it, right? It's not really so high yield for you to know for the exam. But the only thing you need to know for the exam is where it's gotten from and the histology. So let me go to the histology for you. So you can see that it has this um kind of like rosette. How many of you guys know what a rosette is? Let me draw a rosette for you guys so that you can see what a rosette is. So rosette is kind of like you have a cell here, you have a cell here, you have a cell here.
It's like beats.
And then you have
Beats.
another, yeah, like beads. Yeah, exactly. So you have one here, you have one here, you have one here, you have one here, you have one here. Yeah, kind of like beads, right? But for the ependymoma, you have kind of like perivascular rosettes. So basically, the cells are here, the cells are being formed here. But what happens is that the center part here has blood vessels, has a blood vessel, basically, right? So you have this rosette around it, like the rosette, like the bead-like stuff, and then like the rosettes, the beads like are surrounding what we call like a vessel, kind of like a blood vessel, and that's what you're seeing here on this slide. That's what I was trying to show you here. Yeah, something like this, right? These are like tiny blood vessels, and then you can see the rosettes like around the vessel here, right? So these things are called perivascular pseudo-rosettes. If you can put them in that way, that's a way to kind of like remember it, right? It's not so commonly tested in the exam. You just have to know it. I wouldn't say you should stress yourself so much about it, right? The next tumor we're going to talk about, I think that's that about that for ependymoma. I don't really have so much to dwell on it because it's not so heavily tested in the steps, right? Okay, so the next one we're going to talk about basically is the I don't know if you guys know this one. This one is much more common. So let's talk about it. The craniopharyngioma, very common tumor. So it's gotten from particular. So I call the craniopharyngioma the tumor, the C tumor, the C tumor. So like kind of like, let me explain it, right? What I mean. So it's like the C tumor. So it's like the C tumor, right? So things that why do I call it the C tumor? The first thing I want to let you know that it's found in children. That's the first thing. So very rarely for you to find it in adults, mostly found in children, right? Mostly found in children. The other thing you need to know is that it's often calcified. When you see it in an exam, it's usually calcified. And then the next thing you need to know is that it has these cholesterol crystals. Cholesterol crystals, right? This is the high yield things you need to know for the exam. I'm not going to like take my time and say a lot of unnecessary things you don't need for the exam. So these are like the C's. And then the next thing you need to know is the derivative. It's gotten from where? What we call the ractase pouch, right? So does anybody know what the ractase pouch is? Does anybody know what the ractase pouch is?
The remnants of.
Anybody?
Anterior pituitary
Like,
arise
remnants
from
of
the
what?
ractase pouch. It's the embryological. It's
The
the
remnants.
embryological remnant, and it's the anterior pituitary arises from the ractase pouch.
All right. So it's a remnant of the primordial cells that go on to form the anterior pituitary, basically, right? So usually they'll tell you in the exam, there's a word they used to describe this crystal oil. So they'll tell you that it has a solid and often calcified component, and then a liquid oily component. That's the word they used to describe this crystal oil, right? You must know it for the exam. This is very high yield. It's very high yield. You must know this for the exam, right? Does someone have a question? Okay, nobody has a question. So you must know that for the exam because it's very high. I cannot overemphasize that, right? You need to know that for the exam. It's very, very high this year, right? You need to know it for the exam, right? And then the next two more we're going to talk about is the Baba, which is the pilocystic astrocytoma, right? So I'm just going to explain it, use my time to explain it here using this slide, right? So the pilocystic astrocytoma, basically from the word pilo, right? Meaning that it has piles or pilosis, right? So what do I need to know about the pilocystic astrocytoma, right? The first thing I need to know is that usually it's the commonest tumor in children. It's the commonest in children. Commonest in children. Actually the commonest in children. It's gotten from the astrocytes. So of course the tumor marker for the astrocytes is actually the GFAP. GFAP, right? So GFAP, right? So you need to know that. That's also very high yield. Another thing you need to know is that it's a supratentorial tumor. So I drew this thing for you guys the other day where I said this is the brain, this comes down, this comes down, and then you have temporal cerebellum. All right. So the pilocytoma, the pilocystic astrocytoma grows in this region here. So it's supratentorial, as against the medulloblastoma that's actually infratentorial, that's below the temporal cerebellum. Okay. So how do you recognize this on the X-ray? It's very aggressive. It's a very aggressive tumor. That's the first thing I want you guys to know. Very aggressive tumor. Usually located in the posterior fossa, just what I said. It's benign and it has good prognosis, but that's not what I want to show you guys. What I want to show you guys now here is how do you locate it, right? Usually posterior, the posterior fossa. So this is how it looks like, right? Right? This is how it looks like. Finger-like projections. Finger-like projections is what you see on the gross specimen of the brain. And then you see what we call these rosental fibers. These rosental fibers, you can see they're like corkscrew, kind of like eosinophilic rods. So they are like corkscrew eosinophilic rods that you see on the histology. You have to note this. Like when you see this on histology in a brain tumor, I want your mind to go to polycystic astrocytoma. You cannot miss it. You cannot miss it, right? You cannot miss it. I think that's like the high yield thing about it. I don't know if you have any questions about the pilocystic. The next tumor we're going to talk about is actually the medulloblastoma, and the medulloblastoma basically is a very unique tumor. Let me show you guys here. So I said that the medulloblastoma is a unique tumor because of the cell of origin, right? The medulloblastoma is what we call the small round blue cell tumor, small round. Right? And it forms what we call the pseudo-rites. On histology, this is what you need to know basically. Pseudo-rite cells. Pseudo-rites, right? This is what you need to know for the histology, pseudo-rites. So let me show you guys how it looks like. Right? Let me show you guys how it looks like. Or hornal rites, you can call them pseudo-rites. So this is basically it, right? So it forms like a rosette, right? These are like rosettes. I don't know what the person that told me that these things looks like beads, right? And then there's a central kind of like structure here called the neuropile. Yeah, this is like a neuropile here, the center. It's not like necrosis like the other ones that you have. It's more like a neuropile. Neuropile is like connective tissue that's associated with a medulloblastoma, basically, right? So these are the cells, basophilic cells, small blue round cells. You can see them, small blue round cells, right? Small blue round cells that you need to know for the exam. And then you should know the derivatives, right? Derivative of it is known as the PNET, primitive neuroendocrine tumor. So it belongs to the PNET cells, the PNET tumors, which stands for primitive neuroendocrine tumors. Of course, there are other cells, there are other tumors that still fall into this group, such as the nephroblastoma, the neuroblastoma. All of them fall under these PNET tumors, right? PNET tumors. So most of these cells do not have a cell marker or a tumor marker. So they are pretty much straightforward in the exam. Let me show you where a medulloblastoma resides. So this is how a medulloblastoma kind of looks like. Usually found in the cerebellum, right? Usually found in the cerebellum. And then the one we're just going to talk about lastly is the pineal gland tumor. The only thing you need to know about the pineal gland tumor, and that's the only thing I'm going to say about it, because it's also it's not so high yield in the exam. It's not so high yield for you guys to stress yourself about it. The only thing you need to know about the pineal gland is that posterior to the pineal gland, right? Posterior to the pineal gland here is the midbrain, right? Is the midbrain. So when it grows so large, it compresses on the midbrain, right? And when it compresses on the midbrain, it kind of stops, causes what we call Raynaud syndrome, which is the patient will have what we call vertical nystagmus, vertical nystagmus. So when the patient tries to look up, there's this saccadic movement of the eye, right? Vertical nystagmus. When the patient tries to look up and then the eyes goes up, they just quickly rapidly come down, as against horizontal nystagmus, right? And then the patient has this light near dissociation, and this upper gaze palsy. So the patient is unable to look upward as well. So upward gaze palsy. These are like the two things you need to know for the exam. These are very high yield symptoms you need to know for the exams. Right? Very high yield. You need to know for the exam. This is what you need to know for the exams. All the other things not so commonly tested. I'm just going to give you what you need for the exams. I'm not going to waste time to talk a lot of stuff here that you guys don't need, right? And I think basically that's about that for the neural tumors. Do we have any questions about neural tumors? Okay, so let me see, are there any questions? Okay. So let's go on to the next topic. The next topic I want to talk to you guys about is actually the spinal cord lesions. Yes, so I'm going to explain something. So I'm going to clarify like spinal cord lesions, right? And I'm going to call it Do you have any questions? I'm seeing people writing comments. Okay, can you hear me now? Am I clear?
Yes,
Okay,
yes,
so
we can hear you clearly.
so the spinal cord lesions, I'm going to like try to classify it in a simple way for you guys to kind of like remember. So I'm going to call the ones that affect children, and the ones that affect adults, right? Right? And these ones that affect children, I'm going to classify them into the asymmetric ones that affect children, like causes asymmetric involvement, and the ones that cause symmetric involvement, right? Right, and then the one that affects adults, right? Also asymmetric, right, and symmetric. Then also under these adults, I'm going to classify it into the ones that affect the dorsal column predominantly. So that means it affects only the dorsal column. Then this one affects dorsal column plus other tracts. And then I'll tell you guys how to differentiate each and every one of them, okay? And what you need to know. So for the ones that affect children, basically, there are three of them, 1, 2, 3. And I'm going to help you classify both of them, right? So for the asymmetric one, you have polio, and then ALS, right? And then for the symmetric one, you have spinal muscular dystrophy or atrophy, anyone you call it, right? So now let me show you guys what happened. This is the spinal cord, right? This is the posterior commissure, right? Right. This is the you guys should please bear with me. My drawings are not the best, right? So I'm going to differentiate between these two for you guys, right? So basically, the symmetric and asymmetric means that it affects one particular limb or it affects one particular limb more than the other, right? For the polio and SMA, basically, it affects the same part, which is the anterior horn cells, right? These are the anterior horn cells or the ventral horn cells. This is the ventral horn cells, ventral horn, right? This is the dorsal horn. So these patients tend to present with, of course, on the ventral horn. Here you're thinking about what kind of tracts will you be thinking about here in this region here? The anterior horns are the ones that mediate tone and muscle, basically, right? Muscle tone and muscle bulk, basically. So when these regions are affected, the anterior horns are affected, basically. The patient presents with signs of lower motor neuron lesions, right? And this includes loss of muscle bulk. You can notice that the dorsal column is not affected, right? The dorsal column is not affected here, right? So loss of muscle power, tone. And this actually leads, because this horn is basically responsible for the reflex arc and also helping to maintain tone, basically, right? And tone is what gives your muscle, that's you're able to maintain that particular shape. When your muscles have tone, they're able to maintain their particular shape. You understand? When there's a loss of tone, the muscles undergo atrophy, basically. So when this part of the new spinal cord is injured, this is actually the gray matter, basically. When this part of it is injured, it leads to muscle power and tone, basically. And so this patient usually presents with flaccid weakness, of course, because it's a lower motor neuron lesion, right? Flaccid weakness. Flaccid weakness. So for patients with both polio and SMA, they present with what do you call it? Injury to the anterior horn cells. But the difference between both of them is that for polio, the patient usually has only one of these anterior horn cells that is destroyed, basically, most times. But for the spinal muscular atrophy, it's usually both of them. So that is why I called the spinal muscular atrophy symmetric. And then I called polio asymmetric, right? Now, the problem is that how do you differentiate the asymmetric components among both of them, right? Polio is asymmetric, but usually the patient doesn't have upper motor neuron lesions, right? So you see the patient have asymmetric involvement of the anterior horn cells, and then there's no upper motor neuron lesion. If there are no upper motor neuron lesions, you are thinking of polio. If the patient has upper motor neuron lesions, you're thinking of ALS. So let me go back to this picture and show you guys, right? So you can see what I'm trying to say here. You can see that here, basically, one of them is functional and the other one is not functional. For both of them are affected, right? Both of them are affected, basically. So the patient will present with, loss of muscle, acute lower motor neuron lesion, and asymmetric weakness, right? But for the spinal muscular atrophy, the patient presents with symmetric weakness, right? So there's floppy baby with marked hypotonia, as long as strong fasciculations as well, right? Now, the ALS is different because apart from the fact that the ALS has upper motor neuron lesions, and these upper motor neuron lesions manifest in manifest in the patient having what we call bulbar palsy, right? So bulbar palsy, or can we say pseudobulbar? I think it's pseudobulbar. So bulbar involvement. Let me just use bulbar involvement. So the cranial nerve of setting of 12 and 10, they are affected. So these patients will present with things like dysphagia, difficulty swallowing, and the likes, basically, because of the upper motor neuron lesion that is involved, and then the fact that upper motor neuron lesions are involved here, right? So ALS has bulbar motor and is asymmetric, right? It's asymmetric. Polio does not have upper motor neuron lesions and is asymmetric, right? But for the symmetric one, we have the spinal muscular dystrophy. I don't know if this thing is clear at all. Is it making sense at all? I'm trying to help you guys classify it, basically.
Yes.
Yeah. So we're going to talk about each and every one of them, and I'm going to tell you guys what is actually involved in both of them, so that you can have an idea of what's going on, right? So I'm going to start with the polio, basically. So for polio, you're going to have a child who kind of has like an asymmetric lower limb weakness, and the patient has no upper motor neuron lesion, maybe had a viral infection, so a couple of like in childhood or something. The patient was not immunized, and then the patient comes down with lower motor neuron lesions, right? And then that's typically how the history goes, right? For the spinal muscular atrophy, this is more of a genetic cause, right? This is more of a genetic cause. So what basically happened is that there's a gene known as SM1, so we call it survival of motor neurons. So the gene involved here that's affected is called SM1, right? SMN. So this SMN stands for survival of the motor neuron. I think that's just a funny way to kind of like remember it, right? And so this gene is responsible for the development of this. And if you're very familiar with biochemistry, this particular protein helps in the production of what we call a spliceosome. Spliceosome. And the function of the spliceosome is that when you have a messenger RNA that has both an intron and an exon, right? So you have this like kind of like the extra exon or right. This is the intron. I don't know if I'm getting this right, guys, because we long have done biochemistry, right? So the spliceosome comes here and kind of like takes this guy out, so kind of like makes the protein a lot more, or it takes these guys out, and then combines the sliced parts together, right? So the spliceosome does that. So this particular protein is needed in the production of a spliceosome, right? So when there is a genetic mutation in this gene, this particular small what's the name again? I'm trying to even remember it. So they call it small nucleotide, ribonucleotide, something. I can't really remember the name, so you guys forgive me. I can't really remember the name right now. So this particular protein is not formed that helps to make the spliceosome, and hence the lower motor neurons have a defective structure. They are not, the proteins that the lower motor neurons need to function and are not formed basically, right? And that's what actually
Is it the
happens.
SNRNP, the
Yes,
small
yes.
nucleotide
Yeah,
ribonucleoproteins? Small
yes. Please,
nuclear
can you tell me the name?
ribonucleoproteins.
Okay,
Yeah,
small
SNRNP.
ribonucleotide. Okay.
Small nuclear ribonucleoproteins. Kind of funny, but
Okay.
yeah.
Okay. Thank you so much. I usually bundle this thing up a lot, right? I bundle it a lot. So let me just explain it here. So, Doc, can you say what the name is again? Small nuclear ribonucleotide
Ribonucleoproteins. Yeah.
proteins. Yeah. So these guys, their basic function basically is to help in the production of a spliceosome. And basically, what a spliceosome does is like it kind of like gets the messenger RNA, The messenger RNA has like two parts. It has the exons, and I think it has the introns. So I think this is the introns, right? And then these are the exons, right? So I think what this thing does basically is that it kind of like splices out the intron. So like the two exons kind of like meet, and then it forms a complete messenger RNA that now goes in, and proteins are now formed with this, right? So it's kind of like kind of helping the translation process. I think that's where this thing is needed, right? So it helps in protein translation. So the thing is that the proteins that are being produced by this process, the lower motor neurons need them basically. the lower motor neurons need them, right? So the lower motor neurons need them. The LM, so the lower motor neurons of the spinal cord needs these particular proteins. And so when they are not formed, it leads to that disease condition, right? It leads to the spinal muscular atrophy. And these patients have bilateral involvement. So they will have flaccid paralysis, they will have loss of deep tendon reflexes, and it will be bilateral. It won't be asymmetric, right? That's the difference. So when you see in a question, they're telling you about a patient who has only lower motor neuron lesions, and then it is bilateral. I want you guys to go towards SMA, not polio. Polio is asymmetric. You know, I told you that the good thing about both of them is that they don't have upper motor neuron lesions. That means the upper motor neuron is not affected, basically. It's only the lower motor neurons that are affected. That's the anterior horn of the spinal cord, right? That's what is affected in both of them. But the only difference between these two is that this guy here is symmetric and this other guy here is asymmetric. I don't know if that makes sense, guys. Does it make sense, guys? Okay, so let's go on. My job is just to make this thing easier for you. I don't want to talk so much so that you guys will not have overload, right? You guys won't have so much overload. That's what I'm trying to do right now. So you can see here that the patient for spinal muscular atrophy, the patient is also known as this Wednick-Hoffman. So you can just know this for exam sake, basically. And then you know the mutations involved. So the presentation is that the patient has what we call tongue fasciculations. You can also see this in ALS as well. You can also see it in ALS. But the difference between these two, like I said, is that it has upper motor neuron lesion, which is what you have here. The corticospinal tracts are involved. The lateral corticospinal tracts are also involved. The corticobulbar and the corticospinal are also involved here. That is why this one has what do you call it? Has that, and it's usually asymmetric. Asymmetric. This is usually asymmetric. That's what I want you guys to know here, right? So, how do you treat the ALS? A very common drug used to treat ALS is called riluzole. Riluzole, right? Riluzole, right? That's the drug used to treat them. So this Rilo stands for the name of the disease, the person who found the disease, known as Lou Gehrig, right? This is the guy that found the disease, the scientist that named the disease. So you can just remember the low in Vilozole. This is how you treat the disease condition, basically, right? So this patient basically will have an upper motor neuron and lower motor neuron. So usually how they bring this question is that they'll tell you a patient has upper motor neuron lesions. Maybe let me just give an example, basically. So the patient will present more like a polio patient, right? But the only difference is that the patient will now be having features subjective of upper motor neuron lesions. So the patient can have corticobulbar and corticospinal. So the symptoms you expect in ALS, right? ALS is that the patient will have maybe dysphagia. So the patient will have dysphagia. They have dysphagia, right? The patient will have hyperreflexia. So in some questions, they might not tell you the patient has hyperreflexia, right? They might not tell you the patient has hyperreflexia. What they will do is that they will now put the reflex on examination. They will not tell you that the reflex of the patient is, let's say, 5+. Or they might tell you that the patient has increased deep tendon reflexes, right? That's what they'll tell you. That's what they'll tell you in the question. These things, right? Or sometimes they can put a situation where the patient will have hyperreflexia. They will write it down, and then in the tone of the patient or the reflex, they will not tell you that the patient has reduced reflexes or the reflex. Can you hear me? Okay, so they will now tell you that the patient has reduced reflex, or the reflex is +0. They might just put it like that, right? And they will now put other upper motor neuron lesions to kind of like confuse you. So I want you to just picture that in your mind, okay? And sometimes they might tell you that the patient has spastic paralysis, hyperreflexia, hypertonia, and then they might not tell you that, oh, okay, the patient now has maybe in another limb, basically. The patient now has lower motor neuron lesion, he now has flaccid paralysis in that left arm. But meanwhile, the lower extremities, he has spasticity, he has hypertonia or hyperreflexia. That's how they basically bring the question in ALS. And another thing that they do basically in ALS is that tongue fasciculation is also common here. It's also common in spinal muscular atrophy. It's common there as well. But you also see it in patients with ALS. I've seen a question in UWorld. I've seen a question in UWorld that a patient with ALS had tongue fasciculation. It's also very common here. Fasciculation. So it's very common in ALS as well. So that you guys should just know that for the exam, right? So now let us go to the other parts, the ones that are found in adults, right? And these are the 3 that are found in adults, right? These 3 here, right? These 3 here. So the major thing that we have to kind of like classify these 2, the major way I classify them is by using the dorsal column. So let me go back here. The ones that are the adult one. So let me draw another table here so you guys can see it clearly. So for the adult one, right? You can use 2 ways, but I am very comfortable with the dorsal column involvement. So here, when there's dorsal column symptoms only, and here, when there is dorsal column involvement plus other tracts. Right? So let me just put it like this so that you guys can get it. I think there's a better way to do this. So the way to classify it is that when the dorsal column is affected, is DC. If the dorsal column is not affected, you have no DC, no dorsal column involvement. And the only example under here is anterior spinal artery syndrome, or that's it. Right? And this dorsal column, you can have the one with other tracts or alone. So let's put alone, other tracts. When a patient has an involvement of the dorsal column, right, the patient will have features such as loss of vibration. So I write it proprioception, vibration, and touch, loss of PVT. If the dorsal column is involved, the patient will have loss of PVT. That's how I just remember it. So proprioception, vibration, and touch. If the dorsal column is involved, if it's not involved, the patient, all this will be spared. So the patient will have proprioception, vibration, and touch. It will be okay. But if the patient doesn't have it, if this DC is affected, right, the patient will have loss of proprioception, vibration, and touch, basically, right? So another thing that the patient will have are things like ataxia, right, and the likes. Those are other things. So for these other tracts, if the corticospinal tract is involved along with the dorsal column, this patient has subacute combined degeneration. If it's only the dorsal column that is affected, this patient has only tabes dorsalis. And this is caused by syphilis. Right? For the anterior spinal artery, this NODC, anterior spinal artery syndrome. So basically, every part of the spinal cord is affected apart from the dorsal column. So this is what you have here. So for the anterior spinal artery is a blood vessel. Let's say this is the anterior part. This is the spinal artery. This is the anterior spinal artery here. And then it sends branches round the spinal cord to this side, right? Stops here. And then it sends branches to this side here. So it means that the anterior horn, this is the anterior horn. So it means that this region here, right? This region here is affected basically. This is the region that is affected. So everything from here like this, everything here. So this patient will present with all the features apart from the PVT symptoms. So the PVT symptoms will be intact. The patient will have proprioception, vibration, and temperature will be intact. But all the other tracts, corticospinal, spinothalamic, all of them will be involved. I don't know if this makes sense, guys. I don't know if this illustration makes sense to you guys.
It's a little bit confusing, doctor. I can't understand.
Okay, so which part is confusing? Let me go over it again. Dr. Margaret, which part is confusing so I can go over
you
it?
said you talked about loss of proprioception, vibration, and fine touch. And then you the tabes dorsalis. I thought the tabes dorsalis is alone. That's where I got confused. I don't how to put them together.
Okay, so let me go over this again, right? Let me go. So I said that the adult spinal cord lesions, right? I classify them. A way of trying to like remember it for exam purposes, right, is by classifying it, right? I classify it into these two lesions. I look at the dorsal column, right? The first thing I do is that I look at whether there's a dorsal column involvement or there is no dorsal column involvement. That's the first thing I do for the adult lesions. And I said that if there is dorsal column involvement, the patient will have loss of proprioception, we have loss of vibration, we have loss of touch if there is dorsal column involvement. If there is no dorsal column involvement in the question, it means that the patient's proprioception, vibration, and touch will be intact. It will be spared. That's the first thing you have to do. So when you are classifying the two of them, okay, so when you're classifying the two of them, you ask yourself in the question, is there dorsal column? So first of all, you look at the age of the patient. How old is this patient? Is this an elderly patient or is this a child? If this is an elderly patient, you are thinking of three disease conditions. You're thinking of dorsalis pedis, you're thinking of subacute combined degeneration, and then you're looking at the anterior spinal artery syndrome, right? Those are the three things you're looking at if it's an adult. Now, how do you not differentiate between these these syndromes or three disease conditions? You ask yourself, okay, does this patient have dorsal column involvement? What do I mean by dorsal column involvement? Dorsal column involvement means that the patient won't be able to feel proprioception, will not be able to feel touch, will not be able to feel vibration. Basically, that's what I'm trying to say. Let me show you guys by this diagram here. You can see that dorsalis pedis, dorsalis pedis and subacute combined degeneration have dorsal column involvement. This is the dorsal column. It has it. But the anterior spinal artery does not have. These places are spared because the posterior spinal artery is supplying these regions here. I don't know if it makes sense to you guys. Does it make sense, guys? Okay, great. That's the first thing I want you guys
Yes,
to.
perfect.
Yes.
Yeah. So now, I now went further. I now went further to say that, okay, if the dorsal column is involved, how do I differentiate the two disease conditions that affects the dorsal column. And I said that, okay, if it's only the dorsal column that alone that is affected, let me show you guys what I'm saying. So in the tabes dorsalis, you can see that it's only the dorsal column that is affected. That's the only tract that is affected here. There's no corticospinal tract. There's no spinal thalamic tract. Do you understand what I'm trying to say? So if
Yes.
it's only this,
Yes,
if
yes.
it's only this that is affected, if it's only the dorsal column that's affected, that means the patient will present with only loss of pain, vibration, proprioception, and loss of deep tendon reflex. That's all the patient will present with. That is all. The patient will not present with any other thing like corticospinal tract involvement or spinal thalamic tract involvement or anything at all, right? That's what I said for tabes dorsalis. That's what I said. So the patient will have loss of PVT plus deep tendon reflex. So this is how dorsalis pedis will present. This is how it will present. So it will have loss of proprioception, vibration, and touch, plus loss of deep tendon reflex. That is how it will present. This is the only thing you see in the patient. And they might tell you in the question that, oh, the patient had a sexually transmitted infection one time, like that. That's how they tell you, right? But if the patient has this loss of pain, proprioception, vibration, temperature, deep tendon reflex, and the patient is not having other involvements such as, for example, here, the patient is not having involvement such as the patient, you're not seeing the question that the patient is telling you that, oh, the patient has ataxia, is an unsteady gait. Right? The patient has ataxia and unsteady gait, or the patient is now having maybe lower motor neuron lesion, right? Or upper motor neuron lesion. Let's say the patient is now having spastic paralysis. Let's use that as an example, spastic paralysis. Let me clean this thing so that you guys can understand it. Let me just clean here. Or they now tell you that, oh, the patient is now having spastic paralysis. The patient is now having let's say hyperreflexia. He's having something that has to do with the corticospinal tract or the spinocerebellar tract. So SCD, the spinal, this what do you call it now? The subacute degeneration, right? And this is actually due to vitamin B12 deficiency. This is vitamin B12 deficiency. So in the question, you now see the patient is having features of dorsal column, right? The patient is now having maybe, let's say, called the corticospinal tract, and then maybe the patient is now having spinocerebellar. So the patient will have ataxia, yeah. The patient here will have spastic paralysis or hyperreflexia or something like that. Spastic weakness, right? In addition to the loss of the PVT symptoms, right? When you see this in a question, when you see these three triads in a question, the patient is having PVT, spastic weakness, ataxia. This tract here is the spinocerebellar tract. Yes, it affects it sometimes. And then the corticospinal tract. So you can see that these are other tracts in the spinal cord, right? Which is what I'm trying to show you guys here. You can see that this part here is affected, right? The corticospinal tract and the cerebellar tract, right? That's what I'm trying to tell you guys here. So the patient will have subacute combined degeneration if the patient has dorsal column plus other two tracts here. I don't know if this makes sense, guys. I don't know if it makes sense at all.
Yes.
Okay. So Fatima, did you get the adult lesions? Did you get it?
Yes,
sir.
perfectly.
Okay. So let's move on. Let's move on, guys. We have a lot to do. So that's basically that about that. Then for the anterior spinal artery, the patient will have all the other things that I told you guys: loss of pain, corticospinal tract involvement, but there will not be dorsal tract involvement. Then another thing you need to know about the exam is this: It's usually after an aortic aneurysm repair. This is very high yield. This is very high yield. They'll put in a question where a patient had an injury or is hypertensive, underwent a surgery, then all of a sudden the patient can't is having spastic paralysis at a particular lesion, at a particular part of the limb, and then is now having also a loss of temperature and sensation in that particular limb. You understand? So that's how they usually frame the question so that you don't get confused. So usually it's usually a patient who has an aneurysm repair, and then the patient all of a sudden starts developing spastic paralysis, and then the patient is now having loss of pain and temperature below the lesion, below that part that was done. Let's say the aneurysm was at the thoracic aneurysm. Then the patient had an operation that was done to repair that, and then all of a sudden, the patient will now be having spastic paralysis at the lower extremities, and then loss of pain temperature bilaterally at the same extremities. When you see that in a question, I want you to think of anterior spinal artery occlusion. This is what should come to your mind. I don't know if that is straightforward for you guys. Okay, so let us go to the last thing I'm going to talk about before we finish neurology properly. Okay, Nasiruddin, do you have a question?
Yes, but can you please say it again?
Okay, so I said that so let me just explain it. Let me write it down so that you can get it, right? So what happens here is that for the anterior spinal artery occlusion, right? The question typically presents with, let's say, a 65-year-old man, right, that had an abdominal aortic aneurysm repair, right? And then few weeks later, the patient has loss of pain and temperature. And then the patient also has spastic paralysis or spastic weakness, right? When you see this in a question, the answer can only be anterior spinal artery occlusion. Why? Because the spinal cord has innervations, right? So let me draw something for you guys so you can see. Has blood supply to it. The spinal cord has blood supply to it, right? So let's say this is the spinal cord going down, right? Spinal cord going down. The spinal cord is going down, right? So the aorta just directly sits like anterior to the vertebral column, or how do I put it? Yes, sits directly anterior to it. So if there is an aneurysm and the doctor is carrying out an operation, he can easily just sever the anterior spinal artery. So this is spinal cord, right? This is spinal cord. This is the anterior spinal artery, right? So it gives out branch to this region here, right? These are the branches. And then you have the posterior spinal artery that also gives out its own branches to this region here. So if there's an injury to the anterior spinal artery, this is the anterior spinal artery. How many of you guys remember the circle of Willis drawing that I drew for you guys? The anterior spinal artery is gotten from which artery? Where does it come from, basically? The anterior spinal artery. Can you guys remember that diagram where I drew this guy here?
Vertebral arteries.
It's from the vertebral artery.
Yes.
Really.
Yes. So these two arteries are known as the anterior spinal artery. Yeah. So it's gotten from the vertebral artery. This is the vertebral artery. Yeah. So if there's a damage to this anterior spinal artery, it means that all this part here will be affected. That means only the dorsal column will be spared because the dorsal column is supplied by the posterior spinal artery. Now, if this happens at the level of T8, the artery that from this level, I told you guys that the vertebral artery is what gives rise to the spinal artery. When it gets to the level of T8, the spinal artery no longer comes from the vertebral artery. It actually comes from the aorta. That is why the aorta, injury to the aorta is a big issue, right? That is why an aortic aneurysm repair causes this anterior spinal artery, because why? Anterior spinal artery that comes from the aorta is also known as the artery of Adams. I don't know how to pronounce this. So the artery, this artery here, supplies the anterior spinal artery below the level of T8. And that is where most of the aortic aneurysms occur. So an injury to this artery, this anterior of Adams-Kerwicks, Adams-Kerwicks is the one that causes the anterior spinal artery occlusion. So you must know this for the exam. It's high yield, right? I don't know if that answers your questions, Adam. Yes, exactly. Arteries of Adams-Kerwicks, yes. So Nasiruddin, this is the artery that usually gets injured in aortic aneurysm repair. So the patient will present with loss of spinothalamic tract and corticospinal tract. So I don't know if that makes sense.
Yes, thank you.
So let's continue and try and round up neurology. So we're going to talk about Brown-Séquard. What you need to know about it, it's very high yield. This comes out in the exam a lot, so it's very, very high yield. I'm just going to explain it quickly, right? And how I'm going to explain it quickly is by drawing an illustration of something for you guys to just see, because we have to round up, right? So, in the spinal cord, right, there are some tracts that decussates at the level of the spinal cord. So it decussates here, crosses over, and then ascends anteriorly, right? The only tract that I know that does that is the spinothalamic tract. The others, the ones for the dorsal column and the corticospinal tract, they decussate at the medulla. So they decussate at the medulla. So if you have an injury to this part here, injury to the spinothalamic tract, the patient will present with ipsilateral, the patient will present with ipsilateral, what do you call it now?
Pain,
At the level,
temperature.
presents with ipsilateral spine. Yes, ipsilateral pain and temperature at this tract, and then contralateral hemiparesis at that level, right? At that level. So we're talking about, let's say it is C8 now. At the level of C8, the patient will present with ipsilateral spinothalamic involvement and then contralateral hemiparesis, right? The patient will present with contralateral hemiparesis. But below the lesion, because it's coming down, and of course, it decussates in the dorsal column, and then the corticospinal tract decussates in the middle. Below that level, the patient will have ipsilateral lesions, right? All ipsilateral lesions. But at that level where it cuts in, where the injury happens, basically, you have ipsilateral corticospinal and then contralateral hemiparesis. So let me just go to this thing to explain what I'm trying to say here. So you can see that at the level of the injury, there is an ipsilateral loss of all the lesions because all the tracts pass through here, whether it decussates or it doesn't decussate, right? The patient also has ipsilateral lower motor neuron lesion because all the tracts passes at that level, right? Whether it decussates or not. So there'll be flaccid paralysis at that level. That's what we're trying to say. You can see there's loss of all sensation at where it happens. And then there's a lower motor neuron sign at that same level where the injury happens. But what happens here is that the parts that have already decussated in the brain here, so it decussates at the medulla. So this is the brain, is coming down. So let me draw this so that you guys can see. So let me draw this so that you can understand. So at the level of the lesion, all tracts are involved. Basically. All of them are involved. So there's ipsilateral involvement of all the tracts, ipsilateral, at the level of the lesion. Ipsilateral. But there are some certain tracts that crosses at the medulla. So this is the medulla, and this is the spinal cord, right? So the tracts, this is the medulla, this is the spinal cord. Let's say this is the spinal cord, right? So the tracts, they enter into the spinal cord. They go in the same ipsilateral position, and when they get to the medulla, they decussate. This tract is the dorsal column and the corticospinal tract, right? Sorry, no, not the dorsal column. The corticospinal tract and the spinothalamic tract. These two tracts, basically. So below the lesion, so if you go down the lesion, basically, if you are going down the lesion at the level of where the injury occurs, the patient will have, below the lesion, will have contralateral involvement. So this is the part that is coming from the brain, right? So it will be contralateral because it has already crossed already at this point. So it's actually a contralateral fiber that is going down, not an ipsilateral fiber. That's what I'm just trying to say here. So for the spinothalamic tract and the corticospinal tract, you can see, especially the spinothalamic. For the spinothalamic, you can see that what happens at the spinothalamic is that the patient has contralateral loss of temperature and pressure below the lesion because of damage to the spinothalamic tract. But the other two down the tract, because they don't cross at the medulla, it's usually ipsilateral. That's what I'm just trying to say here. So what you just need to know for Brown sequard basically is that below the lesion, it's only the spinothalamic tract that is contralateral. So spinothalamic is contralateral below the lesion. What you just need to know, let me just summarize this for the exam, right? If you are faced with a situation of Brown sequard in the exam, you just need to know that below the lesion, that is, let's say the lesion is at C8, below this lesion here, you only have contralateral loss of pain, right? And temperature. Every other thing, whether above or whether at the level or, all of them are ipsilateral. All the lesions are ipsilateral at the level of the injury. All of them are ipsilateral. Below the lesion, it's only the corticospinal tract. It's only the corticospinal tract and the dorsal column that are ipsilateral. The spinothalamic is contralateral. So let me summarize again. When you see a patient with Brown-Séquard syndrome, let me say this and summarize it once again. When you see a patient with Brown-Séquard syndrome, at the level of the injury, where the patient was stabbed, usually they'll tell you that the patient was stabbed by a knife in the back and it transected the spinal cord. At that level where the knife transected the spinal cord, all the sensations, whether corticospinal, whether spinothalamic, whatever, they are all injured. They are all ipsilateral. Then below the lesion, the only thing that is contralateral is the loss and temperature sensation. That is what you need to know for the exam. You don't need any other thing. You don't need to cram any other thing. That is just what you need to know for the exam, basically, to get all your points on Brown-Séquard, right? So the last one we're going to talk about is the Friedreich's ataxia. So what I'm going to talk about here is that the Friedreich's ataxia basically is almost the same. How do I put this now? Okay, so let me write a formula for you. So what I want you to put at the back of your mind is, when you see a patient that has features of vitamin B12 deficiency and tabes dorsalis, when you see two of them, the two features in a question, it is Friedreich ataxia until proven otherwise. If you see the symptoms of subacute combined degeneration, and then the patient also has features of dorsalis pedis as well, right? It is Friedreich ataxia until proven otherwise. And this is usually located in chromosome 9. Chromosome 9. The gene involved is known as frataxin gene. Frataxin gene. I want you guys to know that this is a. Let me go down. I'm wasting time. I want to summarize this because this is the end of neuro. Basically, I'm going to finish neuro on this night, and then we'll enter ophthalmology and ENT, and then I think we'll call it a wrap. So Friedreich's ataxia, right? First of all, it is autosomal recessive. That's the first thing you need to know. There's a gene known as frataxin gene that is responsible for ion transport. Right? This is located on chromosome 9. Chromosome 9. And it's a trinucleotide repeat. So it's a trinucleotide repeat. There are 4 trinucleotide repeats that we have. We have myotonic dystrophy, we have Huntington's disease, we have Fragile X syndrome, and then we have Friedreich's ataxia. So for Friedreich's ataxia, the trinucleotide repeat is known as GA. You can, if you add a T to this, you call it gate, or you can call it gates, right? That is how you remember the symptoms of Friedreich's ataxia. So the patient has ataxia, has corticospinal tract lesions, and then the patient has spinocerebellar tract. So basically, the patient just has subacute degeneration plus tabes dorsalis. Basically, has the 2 features of both of them, right? That's the first thing you need to know. These patients tend to have foot disorders, right? They have foot disorders. They have kyphosis, right? Kyphoscoliosis. They have foot disorders, kyphoscoliosis. There's another condition we're talking about that had foot disorders, and that condition was CMT, right? That has pes cavus and the likes, right? And I told you that the way you differentiate this CMT for Friedreich's ataxia is that this CMT does not have any organ involvement, no organ involvement. But in Friedreich's ataxia, the patient has heart involvement and they have pancreas involvement, right? So they tend to have diabetes mellitus and they have hypertrophic cardiomyopathy. So when you see a patient that has dorsalis pedis, tabes dorsalis, and subacute combined degeneration, and that has features of DM and hypertrophic cardiomyopathy, I want your mind to go to Friedreich's ataxia, right? What do you need to know for the exam again? They have food disorders, which was I told you. They have diabetes and hypertrophic cardiomyopathy. This is the cause of death. This is high yield for you to know for the exam. Hypertrophic cardiomyopathy is the cause of death in these patients. You have to know that, right? I think that is the major thing you have to know here. I'm trying to round up, guys. Sorry, I'm trying to round up so that I can allow you guys go. Trying to round up. Yeah. The next thing we're going to talk about, and the last thing I'm going to talk about before we end neuro, is cerebral palsy, right? Cerebral palsy. So let me just quickly make a fast one about it, and then we're done, because it's already 6 o'clock. I don't want to keep you guys more than 6 o'clock. Right? I don't want to keep you guys more than 6 o'clock. I'm sorry, guys, that I have to rush this, but I don't want to keep you guys more than 6 o'clock. Right? I don't want to keep you guys more than 6 o'clock. Let me just rush this quickly, and then we're done with neuro. We'll start with the slideshow and all that. So hyperreflexia, basically cerebral palsy, permanent motor dysfunction resulting in brain injury. It's a movement disorder. One of the risk factors you must know for cerebral palsy, I just have to write this: cerebral palsy, prematurity is a very strong risk factor that you must know. And they have different types. That the types that affect only just movement, paralysis of the lower limb, and there's one that affects one half of the body. So we have paraplegic cerebral palsy, and we have hemiplegic cerebral palsy. You don't need to know this for the exam. What you need to know for the exam that I'm just going to highlight right now is its presentation, right? Patient has upper motor neuron lesions, intellectual disability, basically having primitive reflex. All these things are the presentation. These are what you need to know for the exam. And then this as well is very high yield, periventricular leukomalacia. When you see this in MRI, I don't know if they brought an MRI scan of it. Okay, they didn't bring it. So when you see that in an exam, I want you to think of cerebral palsy. How do you treat muscle relaxant? You need to know this. This comes out in an MBME. I've seen this in an MBME question. So you need to know that. How do you prevent prenatal magnesium sulfate, especially for patients with prematurity? You try to give them magnesium sulfate to help brain development. That's basically what you need to know for the exam. I've explained this before. I've explained this thing before, where I mentioned that in this thing, where I mentioned 12 plus 5 goes to the affected, and then 10 plus 7 goes to the unaffected. So basically what happens here is that the cranial nerves, right? If you want to know in the exam which part does the deviation goes to, this is the trigeminal nerve, it supplies the tongue. This is the hypoglossal nerve, supplies the tongue. Trigeminal nerve supplies the face, right? So if you want to know when there's a left or right hypoglossal nerve involvement, it will deviate it to the affected side. So if the left hypoglossal nerve is affected, it will deviate it to this left side. In contrast to a facial nerve, if a patient is smiling, for example, right, the facial nerve innervates muscles that tends to pull here and pull here. So it pulls it to the left. The left facial nerve pulls it to itself. The right facial nerve pulls it to itself. So if the right is injured, the smile will go towards the left-hand side. So it will go towards the unaffected side. That's what that diagram is just explaining. That's what this diagram is just explaining, right? Okay, so the mnemonics for that is PACE-MED. That's the mnemonic for that, right? PACE-MED. Okay, yeah. So let me try and round this up. I'm not going to talk about the upper motor neuron lesions and lower motor neuron lesions of the facial nerve. You guys know this. I'm not going to dwell on this. I think almost everybody knows this. The rule to it is that if there's an upper motor neuron lesion of the facial nerve, it spares the upper part because of bilateral innervation. So both part of the cortex supplies the upper motor neuron lesion. So if there's an upper motor neuron lesion, the contralateral one can also help to supply the upper part of the head. So there will be wrinkling of the forehead. But if it's the lower motor neuron lesion, it affects all the parts, both up and lower, because of the facial nerve is affected. The peripheral part of it is affected. Okay, guys. So I've wrapped up neurology. We'll start otology and what do you call it? Uh, Ophthalmology, ENT, slideshow, and then neuropharmacology, right? And then I'm sorry, guys, that I was so fast at the end. I just had to finish this topic so that we can go to other topics. I think it's so long. So do we have any questions, guys? Any question? Okay, if there are no
Doc,
questions,
I
guys, I'll
always
let you
have
guys go so that
a
you can
confusion,
just.
sorry.
Yeah.
Yeah, I'm wondering the corticospinal tract, when it's damaged, does it give you
Yeah.
upper motor neuron symptoms or lower motor neuron symptoms? Because I feel like I've seen both for the same tract and it gets really confused.
Okay, so I think majority of the times the patient usually presents with upper motor neuron lesions. That's what I can say. Majority of the times he presents with upper motor neuron lesions because you know that upper motor neuron involves the brain and the spinal cord, right? So any tract in the spinal cord is an upper motor neuron problem, right? So that's what I'm going to say. Then corticobulbar, of course, from the word corticobulbar, it's also an upper motor neuron tract from the brain to the
Okay,
brain
so
stem.
it never involves the lower one?
I've not seen it to involve the lower one, to be honest with you. I've not seen a question that it involves the lower one. But however, if you do see it, you can also bring it to our attention, and then we can use it as a kind of like learning module to discuss about
All
it.
right. Thank you.
Okay, so are there any confusions, any clarifications, anything that you want me to talk about?
Good evening, doctor.
So,
Review
yeah, Dr.
review.
Shubham. So what's your question?
Good evening, doctor. Can you please review schwannoma for a little while?
Okay, schwannoma.
Yes.
So I was talking about schwannoma as a tumor that is very common in adults. And the first thing I want you to know about the schwannoma basically is that its location. It's located in what we call the cerebellar pontine angle. So it's like, I have to show you guys this so that you can understand it, right? So this is what I'm trying to say here. This is where the schwannoma usually arises from. You can see that this is the pons, right? This is like the pons, and what you have, this extension here is the cerebellum. So it occurs in between the pons and the cerebellum. This acute angle here, that's where you see it most times. That's the first thing you need to know. The second thing you need to know about the schwannoma basically is that the schwannoma tends to involve the cranial nerve 8. Cranial nerve 8 is majorly involved. However, it can also involve cranial nerve 5, and then it can also involve cranial nerve 7, but it mostly involves cranial nerve 8. And then another thing you need to know about the schwannoma basically is that the tumor marker for the schwannoma is actually S100. And the schwannoma is derived from the Schwann cells, and the Schwann cells are derived from the neural crest cells. So in some questions, they can ask you where are the Schwann cells derived from, or the tumor that is causing this patient's dysfunction arises from which cells. They can put that in a question for you in UWorld or in the exam, right? The last thing you need to know about is the histology. So basically, I remember the schwannoma to be like a hamburger, right? It's a biphasic tumor that's like a hamburger. It has two parts. It has the bread part. The bread part is like the hyperdense part of the tumor, right? And then it has the hypocellular region, or the hypocellular region that doesn't have a lot of cells, basically, right? So I picture that part to be the bread and the cheese, because why? The bread and the cheese has fenestration. So let me go back to show you what I mean. So you can see that in the schwannoma, right? You can see that these cells are numerous here. So this is the hypercellular region of the schwannoma that looks like a bread, like looks like the hamburger bread. And then this region here that you're seeing that has this a lot of like white aspects here is the hypocellular part. Now they will also tell you that this hypocellular side is actually myxoid. It has a lot of connective tissue, right? A lot of connective tissue and fat. That is why it's having this hypocellular region and these translucent things you are seeing. So how I remember it is that when you have the hamburger bread and the cheese has a lot of fenestrations, right? Those fenestrations is what I kind of like liken to this hollow things that you see here, right? These hollow things that you see here. So that's what you need to know for the schwannoma. That's the histological variant. The MRI, you need to master this picture. It's located at this angle here. You can see there's an angle here, usually here, usually here. The schwannoma usually arises from this region here. And the reason why it arises here is because most times the cranial nerve 8 actually exits from this cerebellopontine angle. So that's why it usually arises here. I don't know if that is a very good summary of uh, of the syndrome. Okay, guys. It was a nice session with you guys. I'll see you guys on Monday, so we can start the slideshow, neuro ophthalmology, and all that. Yeah, I like
Thank
hamburger.
you,
I like
teacher.
hamburger a lot. Yeah, I like hamburger a lot. Yeah.
Thank you, Doctor.
Yeah. So you guys are
Thank you,
welcome. I'll
doctor.
leave you
You
guys
said
for.
we are starting with what? What are we starting
We'll
with
start
next,
with
please?
ophthalmology. Yeah, ophthalmology and ENT. And then I'll do a slideshow in between for all the neuros we have done. I'll do a slideshow. And then on Tuesday, we'll do pharmacology. And I think we're done with neuro. So we'll be finishing neuro on Tuesday.
Hello, sir. Sorry to bother you, but if you have a minute to spare, could you please review Brown-Sequard syndrome again?
Okay, so
Can I do it?
okay, so the Brown-Sequard syndrome, right? Usually they usually bring it like this in the question, in the U-word question. I just want you to understand. I'm trying to teach you what's exam focused, right? Usually they'll tell you a guy who was robbed or who had an injury or a stab wound to the back, right? Let's say he has a stab wound at C8. Let's say he has a stab wound at C8, right? So he has a stab wound at C8. So he has a stab wound at C8, the level of C8. This is spinal cord. He has a level of C8. Now, I said that for the injury at that level, at C8, all the motor and sensory symptoms are ipsilateral. Motor and sensory are ipsilateral. They are ipsilateral. They are ipsilateral, right? That's what I said. Now, when you come down this injury side here, down the spinal cord, all the other sensory and motor are ipsilateral. They are ipsilateral, except all of them are ipsilateral, except all of them are ipsilateral, except the spinous thalamic tract that causes loss of pain and temperature. So what I'm trying to say in summary is that if you see a Brown-Sequard syndrome, right, I want you to draw this and just remember this rule. At the level of the lesion, both the motor and the sensory are all ipsilateral. That means it's the same side that is affected. But when you go below the lesion, all the motor and sensory symptoms are ipsilateral except the spinal thalamic tract that innervates pain and temperature. That one is contralateral. I don't know if this is a very beautiful
Yes, so that
summary.
was very clear. Thank you very much, and I hope you have a lovely day.
Yeah, you too. Thanks, guys. Let me allow you guys to. Yes, after the explanation, you guys can read Opto and Auto from FA2. Yeah, so we'll talk about that. I'll talk about the high yield things in both of them, ophthalmology and otology, and then we'll have our slide session, and then on Tuesday we'll do neuropharmacology, and we're done with neurology. Inshallah. Okay, guys. So thank you guys for having this session with me. I wish you guys success, and we'll have subsequent classes together. I hope I'll be able to explain this thing to the most basic level for you guys. And you guys have a lovely day.
You too, Baba.
Yeah.
Thank you, Doc.
Yeah.
Thank you.
Thank you.